So I'm Anne Remmers, say my name properly would help. And shout out for the Southwest. How many people from the Southwest in the room? Great, lovely. I'm also really pleased to be in Wales because I am half Welsh and I was born in Haverfordwest, and my mother's family are all from Aberdare. I did learn a few Welsh words when I was growing up, but I'm not sure if I can say them or not. But my uncle Trevor taught me to say that very long station, Llanfair, Pwllgwyngyll, Gogerydd, Gwyndraobo, Llandisilio, Gogogoch. So I've remembered that since the age of 5, and still it's not enough Welsh, I know, but a little bit there. So yes, my career has always been in nursing to start with, and then in midwifery, and really had that opportunity to try and make a difference to maternity care and improving care for mothers and babies. And I kind of got interested when I was clinical director for Women's and Children's in how different parts of organisations work together and share and learn, but then wider how different organisations can work together and network to improve care for mothers and babies. The clinical network, maternity clinical networks, were set up in 2015, and they were the first. It was the first time that we actually had strategic clinical networks for maternity and children's services. There are a number of other clinical networks: mental health, the cancer, which is now the Cancer Alliance, and cardiovascular. But this was really a fantastic opportunity for us in maternity services to really have that opportunity to improve services for mothers and babies, to improve outcome, and above all, to reduce variability across a regional area. So my role with the clinical network's very much been focused on that, and my role with the West of England Academic Health Science Network's been around patient safety, and particularly maternity and neonatal care. And the Academic Health Science Networks contribute to running national programmes. They work with academia, industry, health services, and really try to work with organisations and seek out innovation so that we can get those new ideas and support those so we can bring about change to improve care. So the drivers for improving care for mothers and babies, I suppose they're quite obvious really, but overall we're trying to improve outcomes and experience. And it's so important. It's such an important time in a woman's life and in that child's life to have the best start in life, to ensure that they have a good quality life, thinking about physical and mental health, how that can really contribute not just to the health of the family, but also to society as well. So that's clearly we've got some aims, and we've got some responsibility around that. And I suppose what the networks really can do is to bring everybody together who are working with mothers and babies and families to reach that aim. So in England, as you referred to earlier, has the Maternity Transformation Programme, and this followed an extensive review of maternity services in England, very much involving women and different organisations that worked with women and families, maternity and neonatal care, to ask them what they wanted from their maternity care, what was important to them. And out of that Maternity Transformation Programme, we've got these 9 work streams that covering everything from workforce to digital, to the payment system, to safe care and supporting local transformation. So out of all of this, we've got some really big policy programmes. And across England, these are being delivered by the local maternity systems. which are groups of organisations aligned to commissioning providers that are providing care for mothers and babies, and they're developing their plans and implementing the recommendations of the Maternity Transformation Programme. And to really kind of sum up what the aim of Better Births was to give all women safe and personalised care, and that's women from all backgrounds and wherever they may live, and whatever their sort of circumstances might be. And it's about improving not just outcomes but experience, because we know how important the experience in childbirth is for the whole family. Continuity of carer has become one of the, I suppose, the leading comments that came from women was that they wanted to know the midwife that looked after them during their pregnancy and when they go into labour. And you're absolutely right, it is a big challenge as well. But that is definitely part of the national policy, and there are models of care that are being tested and tried across the country at the moment. And we do know that the evidence is that continuity of carer actually does improve outcomes and experience. So the evidence is there, it's finding the way of making it work. And of course, safety is always the number one priority for mothers and for healthcare professionals who are looking after mothers. Women and families were very much, as I said, they were very much involved in the National Maternity Services Review, and that's really set the platform for the whole Maternity Transformation Programme. So we have Maternity Voices partnerships, which are groups of women working with commissioners and with providers, very much a part of the local maternity systems and assisting in implementing Better Births. This is a picture of the Whose Shoes game, which I'm sure some of you will be familiar with. It's a great way to involve women and families in having those conversations with staff about their experiences, and it's a very non-hierarchical way of having those conversations and listening to women. So that's very much embedded in the whole programme. So really, just a little bit now about the safety side of things, because that's where I've been involved a lot with the Academic Health Science Network. And that's coming from the safety and improvement arm of the Maternity Transformation Programme. We have recently had the National Patient Safety Strategy launched, and this is very much embedded there as the Maternity and Neonatal Safety Improvement Programme. We are just in the final year of the Maternal and Neonatal Health Safety Collaborative, which has run for 3 years, and every maternity trust in the country has taken part in that and been supported with using quality improvement methodology to improve services. And that's been focused on 5 key primary drivers, which I'll talk a bit about in a minute, and will be supported through local learning systems as this, when the collaborative comes to the end of its 3 years, it's very much embedded in the 10-year National Patient Strategy, National Patient Safety Strategy, and also in the long-term plan. So the local maternity systems will take on that role in supporting organisations, and I'll talk a little bit about that also in a minute. So the journey to a national maternity safety ambition, clearly we have had a lot of influence, starting with the 5-year forward view, but also at looking at things where we've needed to learn lessons, like in the Morecambe Bay and the Kirkup report, and earlier we were hearing about the Cum Taf and how we really need to use those experiences to learn and how to shape our services as we go forward. We've had better births in 2016, the National Patient Safety Strategy in 2019, and now the long-term plan, which is a 10-year plan. And I think it's fantastic that we still have maternity and neonatal services very much as a part of that plan. I can remember times when it was really hard to get the maternity voice heard. I can remember that both in a trust, in an organisation, and also nationally as well. So I think we really do have a fantastic opportunity that we really need to seize at the moment. So just clarifying, the national maternity ambition is to reduce the rate of stillbirths, neonatal and maternal deaths and brain injuries occurring during or soon after birth by 50% by 2025 and by 20% by 2020. And it links very much with the maternity transformation programme, which is promoting good practice for safer care in Workstream 2. So national collaborative programmes, this isn't the first national collaborative programme, there have been others, and the whole point of the collaborative is to get people working together, everybody involved, and to build a culture of safety, continuous learning and improvement, and achieve a continual reduction in harm, so patients and the public can be confident that care is safer. And I've already talked about the maternity ambition there for the Maternal and Neonatal Health Safety Collaborative. And one of the things a lot of the organisations and the people, midwives and obstetricians, neonatologists who've been going through the collaborative have said they found it's just been a great advantage that it's really brought maternity and neonatal services together, to work closely together. Sometimes in organisations they're in different directorates, or they may be not working on the same things, but they have worked together on a number of these themes. So these are the 5 primary drivers that were chosen really to try and cover as much as possible in terms of maternity care and how we could make a difference. Clearly, reducing smoking in pregnancy is a huge factor and will make a significant difference. Optimisation and stabilisation of the very preterm infant, management of diabetes in pregnancy, management of neonatal hypoglycemia and deterioration during labour and the early postpartum period. So trusts, when they are in the collaborative, will choose one, sometimes 2, but mostly one of those primary drivers to work on. And they will decide what part of that driver that they're going to focus on. So with the smoke-free pregnancies, we've had some of the trusts who've really taken off with this idea and worked together with the neonatal services, and they're undertaking regular carbon monoxide detection, monitoring, not just where in pregnancy, but actually they've taken it into the NICU environment, so they're involving parents, and so there's really that education around having a smoke-free home that's getting that message across in a very real way. And the deterioration, I'm seeing Eleanor there because one of our trusts is working on reducing PPH. And so our networks have been spreading across from the southwest to Wales, and we're learning a huge amount from the fantastic work that you've been doing on the Obs Cymru project, which has been great. So, talking a little bit about how this all fits together, I think I've tried to put it in a slide where it's a bit more simple, but otherwise it does seem quite a complex picture. But the local learning systems are really supporting the local maternity systems, the neonatal networks, the maternity networks, all the services within the trust and community, and ultimately working with mothers and families to continue this improvement. So we're looking at where we've had trusts working on projects within their individual trusts, we're looking at system level improvement. So within our local maternity systems, we may have more than one organisation within that system. For example, in Devon, we've got 4 maternity trusts in Devon. So that's about all working together to try and improve outcomes. One of the first things we did when we set up the maternity clinical network, we asked people what they wanted us to do as a first job, and they said, please, can we have one regional maternity dashboard? So we're really proud that we did develop a regional maternity dashboard for the South West. So evidence is there, people can access their outcomes. We got everybody to sit around the table and to agree what were the indicators we were going to measure, how we were going to measure them, and so everybody inputs their data, and we have real-time information on outcomes, which has been incredibly helpful, because we are looking to a national maternity dashboard, but we aren't quite there yet. So we have got that to work on, which has been brilliant. So my feeling about networks is they basically bring people together, get people talking to each other. And for us, that's really been about having a common aim of improvement. So it's not about what organisation you belong to, what job you do. It's what are we trying to improve, what is really important to mothers and families. And we do spend time reaching the consensus through collaboration. And it's been very successful. And I would say, when we say, well, who is in your network? Who are the important? Must you be a very important person? It's everybody. So we have regular get-togethers with all of the people that work within maternity and neonatal services, and we share ideas and we share sort of projects, and sometimes we're sharing problems and helping each other to solve them. And it's about involving women and their families, and all providers of maternity and neonatal care, commissioners, and they're not just formal networks. I work for 2 formal networks, but there's so many, as you know, there are so many other networks out there, informal networks that we can tap into and get information across to people and get their ideas. So this is the South West. We've got the very beautiful Cornwall and the Isles of Scilly at the bottom. It's a very long, stretched out geography. It's not always that easy to travel around the South West. I think people sometimes get stuck at Bristol but not get any further down. And it's quite a big distance from the bottom of the Isles of Scilly right up to Gloucestershire, which is almost in the Midlands. And these are some of our formal networks. We have a neonatal operation delivery network. We, as every region in the country does, we have maternity network. We have 2 local learning systems, one covering the sort of up until to Somerset, Devon, Cornwall and the Isles of Scilly, and the other, the top part of the region. We have 6 local maternity systems who are working together, and we have 2 academic health science networks. And these, again, just another illustration of the different networks that are working on improving care for mothers and babies, and how we can work together. One of the projects that we are really trying to sort of get working on at the moment with the neonatal network in particular is right place of birth for the very preterm infant. So we know the evidence is there that very preterm babies have a much better outcome if they're born in level 3 NICUs, but they're not always in the right place for various different reasons, and that's about making sure that we've got good transport, we've got good communication, and that we've got good transfer guidelines, and the involvement of all of maternity and neonatal services has obviously been a big part of that. So we can bring in everybody to try and focus on those really kind of big thorny issues. And shortly we should have the National Neonatal Services Review published, and that's going to be place of birth for the very preterm is very much going to be one of the top recommendations there. You may have heard of Precept. Has anybody heard of Precept in the room? Yeah, a few nods. So it's prevention of cerebral palsy in preterm infants. So I put this in as an example really of how things can grow. So we've got a consultant neonatologist who works in Bristol called Karen Loit. She saw that the uptake of giving magnesium sulfate to women in preterm labours to prevent cerebral palsy was extremely variable across our patch, actually across the country as well. And she did quite a lot of work in her own trust to increase that. She had a conversation with us about how we might help to spread that. And so we supported that in introducing it to the other trusts within the West of England, so 5 trusts in total, and we supported it through the quality improvement support, but also some resources for backfill for leadership and midwife time. And when we started the project, we had some of the units were only having 21% uptake of magnesium sulfate, and by the end of the project we had 85%. Our chief executive at the time was at a big meeting with important people, including Simon Stevens at the time was talking about this, and the question was asked, why can't we do this right across the country? And so that is the project then became the National Precept Programme, and this was spread in all units in the country. And we've now got some fantastic rates of uptake, and sometimes we're hitting 100% uptake of magnesium sulfate, and that's going to make a huge difference on the impact of cerebral palsy, with less cases of cerebral palsy, just by introducing and supporting that intervention. So it's a good example of where networks can work together and achieve things. But before I finish, I just want to mention that it's not just the formal networks. There are loads of informal networks out there, as we've been hearing about today, and there's a fantastic wealth of information out there in social media, with lots of ideas about how you can progress, introduce change, and work together, share ideas. So I just listed just a few of them there that you may be familiar with. And just so these are some of the ideas that come out. There's a wonderful illustrator called Sonia Sparkles, which some of you may have heard of. She does the most wonderful diagrams and pictures of. This is one of hers, but she does many more sort of that you can use. And then the other one is from the School for Change Agents. And it's possible to use all of those and to help you with just sharing ideas, really. And I think Sheena's going to be talking about use of social media, isn't she? So that's clearly something that is spreading. And Sheena and I actually, we actually both trained in the same year, 1979. So we've come a long way. So we're trying to keep up with Sheena's well ahead, but with the changes as they go on. So there's lots of stuff going on out there, and I think if you're thinking you've got an idea or you want to find out a bit more, just ask in your own organisation. Ask about some of these. If obviously it's slightly different in Wales, but in the southwest, some of these organisations, but also informally, and so that you can perhaps create your own network and start from there. And I'm just gonna end with a quote that I just saw. I was just reading on the train actually, from somebody called Dan Simmons, who I don't know. He is an author of sci-fi, but I'm not a sci-fi reader, so I don't know. But it's his quote is, "It occurs to me that our survival may depend upon our talking to one another." I think that's very true. Thank you.
Wonderful quote to finish with. I think we might have time for one question. Anyone's questions? At the front, our roving mic.
Have I done for time? All right.
Can I just ask whether you've been able to regionalise your approach to screening for small for dates babies, because this has proved to be a big challenge, I think, in a lot of regions. And if so, what programme do you follow and how is it going?
Well, I think we were probably on our way to regionalising it with using the NPEU and the GAP tool. But I think since then there's been some different views about how to screen. So I would say at the moment we're not doing it on a regional level. There have been some different views about using the GAP tool in some of the units. Some of the obstetricians haven't wanted to use it for different reasons. So we probably still got a way to go if we were going to do that on a regional level. Yeah.
Are any of the units doing routine ultrasound screening?
Yes, some of them are, and I think it's a real challenge. I think a lot of them are doing routine. You mean for small for dates and for reduced fetal movements?
Universal screening for small for dates using ultrasound rather than synthesis from behind.
Yeah. But I think that's been a challenge, both in terms of having the staff to undertake the increased number of scans and the capacity. So I think that's just has in some ways created another pressure for the units. Yeah. Okay.
Thank you very much.
Thank you.
Another round of applause.
Thank you so much.